Buenas tardes a todos. Para mí es un enorme placer estar aquí moderando esta sesión y a continuación voy a comentarlo en inglés, dado que la ponente internacional está de manera virtual y no entiende castellano, creo yo. It is my great pleasure to present our international speaker, Professor Revital Nimri, at this conference of Technologies Applied to Diabetes Group. Would have loved to have been able to meet her in person, but it has been impossible for her to travel to Madrid. Revital Nimri is a senior pediatric endocrinologist and director of the Scientific and Technology Diabetes Unit at the Institute for Endocrinology and Diabetes National Center for Childhood Diabetes, Schneider Children's Medical Center of Israel, and a professor of pediatrics at Tel Aviv University. She has a 20-year track record of expertise in clinical diabetes, and her research focuses on diabetes technology, including continuous glucose monitoring and pumps, and in recent years on new and innovative technologies to improve the management of diabetes. She has received academic and professional awards for clinical research and contribution to the research in diabetes. Welcome virtually to our meeting, Revital. I give you the floor and you can start whenever you want. ברוכה הבאה למדריד.
Thank you. Hello, everybody. Good afternoon.
לא שומעים כלום.
Thank you so much, Sharona, for the kind introduction and for inviting me. I'm honored and privileged to take part in this meeting. As you said, I'm coming from Schneider Children's Hospital, which is the biggest children's hospital in Israel. We are treating around 2,100 children, youth with diabetes and focusing on technology. So this is my disclosure slide. My talk today is about clinical uses of artificial intelligence decision support system. I'm going to start with what do we mean by artificial intelligence? Why do we need it in the world of diabetes? Talk a little bit about available decision support system and the one that we developed with a collaboration. Does it work for healthcare providers and patients? And we'll end with a glimpse into the future of AI in diabetes. So let's start. Today, data related to diabetes treatment can be easily connected. We have devices connected to cloud. We have electronic medical record. We have abundant huge of data that is really, really valuable. And this must be linked to systems that then can process, analyze it, and provide actionable therapeutic recommendations, just like a decision support system. So in brief, decision support system makes sense out of data and support informed decision making. And this system have the potential to improve clinical outcome, increase access to care, enhance utilization of healthcare resources, a telemonitoring program, and particularly important in the context of precision medicine. And what do we mean by artificial intelligence? What is it? There is no clear definition, but the term is often used to describe a machine or computers that mimic human cognitive function, such as learning, problem solving, and decision making. We have smart machines capable of performing tasks that require human intelligence that are already in use, even in complicated, sensitive professions. Here is an example, like in replacement drivers, we have the automated driving car. In airplanes, with automated flight and landing. In surgery, we had the Da Vinci approved FDA robot in operating room. And we also have the automated insulin delivery system, which is a decision support system. We developed such an an AID system in a unique clinical way in Schneider that modulate insulin delivery based on a set of rules that imitate the way we, diabetes practitioner, and you treat patients with diabetes. So we called it MD Logic, Medical Doctor Logic. It was the first system to be tested outside the hospital in a diabetes camp back in 2011. It was done in Slovenia, Germany, in Israel. And now I'm happy that we have commercial devices, and some elements from our system are included in the 780G. So we all know that AID significantly improve glycemic control, and it doesn't matter where you are being treated, the outcome would be the same. And AID as a decision support system promotes standardized care. And I would like to share with you this article. It's a consensus recommendation for the use of AID by a panel of 75 experts. It covers essential aspects of AID, a lot of practical information, and I invite you to read it. You have the QR here. So decision support system can mimic the healthcare thinking process and decision-making, enable personalized therapy. But why do we need it in the world of diabetes? Can we do without decision support system? If I've been with you, you would say, yes, we can do it in the old way, just like navigating with a map. We have plenty of general consensus statement, guidelines that can support diabetes care. But something is not working. The quality of care for people with diabetes is not getting better and even getting worse. Data published recently in the New England Journal of Medicine of adults with diabetes show that in the last decade, only 1 in 4 adults meet all 3 ADA recommendations of care. And less than half achieve the target glycemic control, and even less success among those that are treated with insulin. And why it's hard? Because it's hard to treat diabetes. The burden that it possesses on individual with diabetes, on provider, and also for the healthcare system. We know about shortage of endocrinologists. I don't know what happens in Spain, but in Israel it happens, in the US, of course. We all concerned time constraint in office visit and so on. So yes, we can do without clinical decision support system, but we can do better with decision support system, like ways enable a more effective driving instruction in a simple and effective way. A wide range of decision support systems, such as web-based and mobile phone applications, are available to support almost all aspects of diabetes management and treatment: physical activity, nutrition, examination, and until calculating insulin delivery. And I took all of them and classified them into 4 main categories. One is tool for self-management for people with diabetes, tools for diagnosis, screening and prevention, and prediction tool, and finally, clinical management support tool for insulin dose adjustment and inpatient treatment algorithm. And in the upcoming slides, I will review some tools for each category. So let's start with the tool for self-management. This is a really nice study that I like, back from 2007, that shows that individuals exhibit different postprandial excursion after consuming the same piece of bread. And by that is showing the need for personalized nutrition recommendation. And today we have several apps that are listed here that aim to predict individual postprandial responses, and it can be done with different ways, based on CGM, on microbiome, on body composition. And I would like to share with you one example of such an app that is called Under My Fork app, that combined CGM data with photo-based food logging. People are asked to take picture of the meal, like we are doing all the time. And the app automatically recognizes and tag many foods. The app sort meal into 3 categories based on 2-hour postprandial time in range. By analyzing this data, the app can help on decision on food choices in the future. And another challenge faced individual with diabetes is adjusting the management around physical activity. And here a decision support system can also assist by analyzing glucose, insulin, and nutrition data, along with fitness data. If you have a Fitbit or Apple Watch, to provide personalized advice, even in real time, to support physical activity. And here in this slide, you can see some example. I choose the Diabytes that predict future glucose level using machine learning algorithm. It learns from the past how glucose level will be in the next time you are doing the same exercise. And decision support systems are also available for screening diabetes-related complication. And here's an example of FDA-approved device that automatically identify diabetic retinopathy from fundus photographs. And this is endorsed by the ADA in this last year's standard of care. It is ideal for screening because it can be used in primary care clinic, in rural area, and no need to make an appointment with an ophthalmologist. And we have a lot of other apps that are in development. I found one that in Spain that you can see, and also the Food Snap that enable longitudinal food monitoring by images for early pathology for detecting ulceration. And we have also big data and machine learning to develop prediction tool in precision medicine. This is another category. We have here plenty of idea. Gather some example, like predicting the response to immunotherapy for type 1 diabetes, to customize individual immune therapy. We have data from electronic medical records, blood glucose, blood pressure, and laboratory tests. All can be analyzed to identify pre-diabetes in primary care settings for early intervention, predicting of diabetes only by electrocardiograph without glucose, and so on. And to summarize, this recently published scoping review included 85 articles, and half of them were published in the last 5 years, and it summarized the effectiveness and safety of decision support in diabetes management. And as you can see, the majority were used for treatment recommendation, either for healthcare provider and also for patient. And importantly, 71% of the study decision support significantly improved glycemic control with no increase in hypoglycemia. So hopefully I convinced you all that diabetes treatment should be individualized and one size doesn't fit all, and technology should be tailored and targeted to suit individual needs. And this can be supported with a decision support systems. And such an automated system was developed in called Endo Digital, developed by DreamMed Diabetes in collaboration with Schneider. This is you can see here a diagram that illustrates the system. It's a cloud-based system that utilizes glucose, insulin, and other data uploaded from the various diabetes management devices, uses artificial intelligence for data analysis, and provides structured visualization of the data and suggests treatment adjustment for pump therapy and also for MDI, either for type 1 and type 2. And additionally, it offers also personalized diabetes behavioral recommendations, and all in a split of a second. User review, user received the recommendation through their smartphone after provider approval. And you can see here an example how the system works. This is an old version in clinical studies, so we won't have names of the patients. And you can see here first, the provider enters the population tracker, see that the patient has data, and ask for a new recommendation, tag new recommendation. And you can see in a split of a second, it's get recommendation. It's truly what I photoed. And you can see here the last, what he has, the current buzzer rate and the suggested buzzer rate by the system. The provider can edit the time and the amount, and then scrolling down gets behavioral recommendation. And at the bottom of each page, there is the ambulatory glucose profile, logbooks, daily data, to simplify the reviewer, the provider review process, and then in the same way going to the carbohydrate ratio. You can see here, looking at all the data, if you like to change, you can change, then to the correction factors and seeing all these things again. And once clicking the button of approved, in a minute, yep, on approved, you'll have the report. You can add comments in the report. And once clicking the approve and share button, the recommendation are shared with the patient's smartphone, like you can see here in the picture. So a decision support system is expected to deliver comparable quality of treatment as those provided by expert physicians. So we did several stepwise studies, first surveys, that we see that the recommendation generated by the decision support system were similar to those given by physicians. And then we did a multi-center, multinational randomized control study that showed that clinical outcome were non-inferior, were similar between the decision support and a physician. And finally, I will give you a glimpse on the real-world data, really the early one that we have with the system. So here is one of the survey. We asked 26 expert endocrinologists to provide pump setting adjustment for 15 patient cases. We compared the recommendation between the physician and the decision support system. And you can see surprisingly that the level of agreement on the direction of insulin dose adjustment between physicians was only 45%. So we agreed between us only in 45%. You can see it in red. And when comparing the decision support and the physician, it was same. So the physician and the DSS had the same level of agreement. And in a similar methodology, we did it for cases of multiple daily injections, either in type 1 and type 2. And you can see here we found again a similar degree of agreement between experienced physician and between the physicians and the algorithm recommendations for the same set of patients' data. So we can conclude from this survey and said that we can consider the decision support system as just another team member to consult with, just another friend to consult with, physician to consult with. And then we conducted a multi-center, multinational randomized control study that were conducted in 7 well-known pediatric academic centers in US, Europe, and Israel. And we took 108 participants with type 1 using insulin pump therapy and the same CGM, and they were randomly assigned to receive insulin dose adjustment every 3 weeks by either experienced physician or the decision support. The patient didn't know where the recommendations are coming from. And the baseline characteristics were average age 15.6 years and A1C of 8.4. And after 6 months, glucose control was found to be similar between the two studies arms. You can see here, A1C was reduced in the physician arm and also was reduced in the decision support arm, but the difference between them was similar. Also in time within range and also with clinically significant hypoglycemia range. So the study outcome provide evidence that an algorithm can be fed with human intelligence and get similar results. And here is a glimpse from our real world data. People that used the decision support in a routine care after they're getting the recommendation after the provider approval. And you can see that after 6 months, 48% increased time in range by more than 5%, and 32% increased by 10% or more, and the others didn't change or reduced. And I would like to draw your attention to another important feature of the algorithm is that it detects behavioral management causes for hyperglycemia and hypoglycemia, and present the relevant causes via text messages. As we all know, it's not just insulin, it's also what we're doing, what patients are doing. For example, for causes for hyperglycemia is untreated meal, if someone missed boluses or late boluses, or overtreat hypoglycemia. And for hypoglycemia, behavioral reasons is manual bolus, or override the bolus calculator. And you can see here an example. I noticed that many of your highs may be avoided. Delivering an insulin bolus for every meal and snack will help you get a better result. And you can see here a picture why with a meal without a bolus, and that's why the system said that. So, and it's not surprising that the most frequent behavioral recommendation in the real world data analysis.
If you want to continue
I don't
here.
know if you hear me.
Yeah.
But I talked about, I don't know what happens, but I talked about behavioral reasons for hypoglycemia and hyperglycemia with the decision support system, and 18 providers who use the decision support system in the routine clinic were asked to identify, in their opinion, the key benefits of the software. Interestingly, you can see here, most stated that the key benefit was that the software recommendation facilitate useful discussions with the person with diabetes and family, along with other advantages of achieving dosing changes more quickly and speeding up consultation time. And here is a quote from one of the physicians that said the algorithm has been great at recognizing overtreatment of lows. And so many of my families just smile and say, yes, I do that. It's been helpful. And I would like also to show you that artificial intelligence shows promise in medication titration and potentially overcoming therapeutic inertia. In a recent study, 32 adults with type 2 diabetes in primary care who need insulin initiation and adjustment were randomly assigned to use either voice-based conversation, AI for automatic basal insulin treatment, or standard care. The AI group achieved optimal insulin dosing in 15 days and the standard in 56 days. So AI users also showed that improved insulin dose adherence and the glycemic control was better than the standard of care. So decision support system can help also in this. I brought 2 studies that use the insulin dosing app along with connected pen to adjust insulin doses, this time for individual with type 1 using MDI. And you can see that in both studies, there was no significant change in glycemic control. However, when a subgroup of participants who used the application, the glycemic control was and some kind of glycemic benefits were demonstrated. So technology works when it's used, and this is important to know. And we are currently using the EndoDigital, evaluating it in several studies when recommendations are aimed to be given directly to patients. These studies are supported by the Helmsley Charitable Trust. You can see this single-arm study, 16 participants with type 1 diabetes who use multiple daily therapy, use the EndoDigital app to receive treatment adjustment every 2.5 weeks for approximately 3 months. And at the end of the study, they were asked to fill satisfaction questionnaire regarding the experience with the mobile app and the bolus calculator that is in the mobile app for MDI users. And you can see high satisfaction was reported with the use of the bolus calculator, less time to decide and calculate the insulin dose, and most participants wanted to continue using it. And overall, the bolus calculator improved the comfort and ease of management of insulin dosing for MDI therapy. And here is a meta-analysis of 14 studies that identify 2 key factors for enhancing the adoption of clinical decision support technology. One is successful integration into clinical workflow. So if the decision support is easy to use, it's time-saving, and so on. And the second demonstrated clinical impact, improving care delivery. Achieving this factor is essential for increasing adoption. The AI is integrated. You can see here the EndoDigital is integrated into the EMR, allowing provider to access the system for creating recommendation, reviewing the patient report, and sending the approved plan to the physician, to their patients. Routine use of the AI decision support in 3 endocrinology clinics showed improved effectiveness in clinical visit by reducing the number of steps performed in each patient visit by half, reducing the number of platform use, eliminating printed pages, and actually the most important is standardizing the patient process across clinic within the organization. And another aspect of improved workflow effectiveness is that the use of the EndoDigital frees up almost 9 minutes of staff time, which was previously spent by manual tasks and data entry into the EMR. Finally, decision support system can also support telehealth. We were involved in a VDISC that provide comprehensive virtual diabetes clinic model to support individual on intensive insulin therapy who start CGM use mostly in primary care. The participant used the EndoDigital app and bolus calculator, and the CDCs use the decision support because they give the treatment. So with an awareness of the current gap in diabetes practice and the recognition of AI potentials, the AID, ESD, and other diabetes associations support the use of digital tools and integrating decision support into workflow to support providers in clinical decision-making and treatment adjustment, and people with diabetes for self-managing, marking AI decision support as a potential future direction in diabetes care management. And today there is plenty of research, diabetes research on AI and machine learning. And the New England this month launched a new journal that's called New England Journal of Medicine AI. So I would like to conclude and say that clinical care can be given by the decision support system. It improves clinical outcome in diabetes care, increase access to expert level care, reduce therapeutic inertia, standardize workflow, enhance healthcare resources, facilitate communication and data sharing between provider and individual, and enable personalized medicine. Gracias to you all. Thank you so much. I hope that you heard everything. I'm not sure. And I would like to thank my colleague in Schneider Children's Hospital, the Endo Digital and the DreamMed and the Helmsley for supporting our studies. And thank you again for listening.
Thank you. Toda raba, Revital. We have now 5 minutes for questions, and congratulations for your excellent presentation and for your motivating presentation. ¿Alguien tiene alguna pregunta de la audiencia?
I cannot hear you.
Can...
now I can hear you.
Yeah.
Hi, everybody again.
Yeah, we have
Hope
here...
that you heard me. I didn't know if you hear me all the time.
Yeah. Yes, it's perfect now. Excellent presentation, Revital.
Thank you.
We have here one question. Health data, security, and privacy are very important considerations in the development and use of these technologies. How to ensure compliance and who is responsible for the decisions made by these systems?
This is a great question. I'm not sure that I have a good and solid answer, but we're treating everything that is in the cloud and so on needs to be GDPR, have all the regulatory for cybersecurity and so on. Who is the responsible? It depends. In ours, in the Endo Digital for now, it is only for providers. So providers have the right to override the decisions or accept the decisions. And I do not think that we have one answer how for each application who is the responsible.
Okay, here we have another question for you.
Hello,
Great.
Professor Nimri. Thank you very much for your wonderful presentation. So I am endocrinologist from Valencia here in Spain. My question is regarding another aspect, because you have a lot of experience in Tel Aviv in your work with artificial intelligence. How do you see how these advances in the treatment and in many things, how these advances can be impact the training of our medical physicians? So, because, you know, it's wonderful to have another member team, but I don't know how this will be impact, for example, the capabilities of our medical residents in the future. Because, you know, if you have system that can decide for you, I don't know if you have some experience with it. What is your personal opinion? Thank you.
Good question. Another good question. I see them as tools, as something that support us, the providers. So we need to learn a lot how we can adjust our education and training when using this kind of treatment. And we are already doing it, I think, for every fellows and so on. It was a nice question about the GPT-4 that is now, is it good for education, not good for education? But for now, I think that we are still not there. And these tools, I see them like the bunch of tools that a provider or physician has, and he can use it, he or she can use it. And I believe that in the future, yes, things are different. Just like our smartphone, who is not going with a smartphone and doing almost everything with the smartphone. So it would not replace physicians. It would not replace healthcare professions. It will do, I think, effective time and give you more time to do other things that you don't have time to do that now.
Thank you. We have here another question for you.
Yes, congratulations. Thank you very much for your talk. I have a question. Have you considered the development of some type of decision support system for automatic adjustments in hybrid closed-loop systems?
Yeah, great. Another great question. Well, different systems works in a different way. And the parameters that can be adjusted in different systems are different. But there are systems that all the systems still need carbohydrate ratio. And all the system, this is the main. Some system need basal, some system needs something else. But, sorry, I don't have just connecting to the electricity, a minute. Yeah, sorry. And yes, we're doing decision support to support at the automated insulin delivery. Yes, we need it because children are growing. They are going for puberty and they need frequently adjustment of the insulin dosing in AID. And also one thing that is important from sometimes you don't use the AID because pump failure and so on, and you need to adjust the open loop parameters. So this is a good initiative and hope we'll have it soon.
And the last question, artificial intelligence algorithms learn from data they are fed, and if this data contain biases, the resulting models can generate incorrect or misleading results. How to prevent this from happening?
Another great question. That's true. Our engineers always tell me, you enter garbage, you get garbage. So the data, the quality of the data is really important. So working in places that can manage the data in some way and to verify that the data is accurate and doing all this stuff can prevent from doing garbage in, garbage out. And hopefully that's what happened.
Thank you very much. I would like to thank you for your contribution to improving the life of our patients, not only quality of life, also control, glycemic control. And for me, it's a pleasure to introduce you here. And אני מקווה שבשנה הבאה את במדריד. ורציתי להגיד לך תודה רבה, שבת שלום, וביחד ננצח. Shalom. Con todo el discurso que me he soltado.